Right, so welcome to Medical MCQ for all. As you everybody knows, we are preparing all the doctors for DHA, HAD, MOH, and all Gulf PROMETRIC exam. This is our general things. What we provide 1000 MCQ book and ebook as well. Recently updated 1000 MCQ book couple of months back. We provide online subscription and live coaching by expert, right? So like the way we are doing every Sunday, right? So this is the live class. We provide WhatsApp subscription, we provide Oman coachings and the subscriptions as well. All the data flow services for all specialty. It is done from Dubai only. From Dr. Anjali is taking care of it. We have a short package, especially for those who have second or third attempt and those who wants to guaranteed pass, they have short package. So you just go through it and mobile application. Those who have not downloaded on Android or iPhone, you can get it from our this Play Store, right? Online. And recently we this started one dedicated mock test series. So those who are, I mean, going for the exam and really wanting to get where they are standing and how much is the score and how is the progress after preparation. So they must go for this dedicated mock test, right? So this is Dr. Munjal, and I am a hemato-oncologist and bone marrow transplant fellow. Almost 15 plus years of clinical experience with treated 100,000 patients, delivered thousands of chemos, bone marrow biopsy, and I am member of American Society of Clinical Oncology as well. This is Dr. Aarti, who is a consultant pediatrician, and she is taking lectures for us. She is Dr. Maddie. She is again a internal medicine and cardiologist. So she is taking excellent lectures on ECG, cardiology, and CPR and many internal medicine. Dr. Shikha is recently shifted to Dubai. She was in India. Couple of weeks back, she joined in one of the reputed hospital in Dubai as a consultant gynecologist. So she is delivering the lecture from there now. Dr. Ankit is a gastroenterologist, and this is all our team. So these are our contact details. This is our book, as I told you, and this is the coaching offer now. It used to be a 40 hours. The full fledged coaching was used to be 500 USD earlier, but now it's 250, almost 50% flat discount. So you contact Pallavi or me, and if you are going for one combo offer, you may get other discount as well. Anjali's number is this. This is data flow head Anjali. She is taking care of all the data flows, exam booking, and all logistics. Mock test, as I told you, we recently introduced a module. So you go on our website and give the mock test and get your score, and we'll discuss. And couple of good news. Yesterday we did excellent webinar on the EMRI yesterday night. So we are coming up with the EMRI. EMRI is a Emirat Medical Residency Entrance Exam. So those who wants to get into the residency of gynec, pedia, surgery, blah blah, they can go for this EMRI exam. So we are launching the course very soon. Probably next month I'm visiting Dubai. So probably at that time we'll launch this, and dental UAE program we are also launching. So let's start and go to our main subject. So get everyone ready and try to interact with the questions. These all are absolutely high yield questions, so I would be glad that if you can interact and try to utilize your brain. Just don't, I don't need just ABCD answer. Try to understand what's the logic, right? So first questions in front of your screen. A 30 years old female presented with hypertension, proximal muscle weakness, weight gain, especially in the upper body and purple stria on her lower abdomen. Which of the following test gives a clue about the etiology or probable, most probable diagnosis? So which test? High dose dexamethasone, 24 hours urinary cortisol, low dose dexamethasone, midnight salivary cortisol, all of the above. I'm interested in these three things, right?
All of
What I'm interested in is what is the diagnosis, right? These are the things I am interested in. What is the diagnosis? What is the investigation? And what is the treatment? So your time starts now. You think over it, because if the same question it comes in exam, what you supposed to answer? Yes, Varun. Now we start with you. So what do you think? What's the diagnosis first of all? And as I earlier told you, let me once again remind you, everyone, those who are new in
260.
this class, if you are not interacting, sir, please make your mic mute. It's my humble request. Otherwise, I cannot concentrate. So this is what the thing is. So let's check, right? So this is a triad, right? Again, I mean, many people may forget, or some people are new in this class. So let me draw the triad, right? So this is the triad in which, right, there are three things in triad, right? You need to know diagnosis, you need to know the investigation, and you need to know the treatment. So now let's start with the Varun. As you explained, it
Yes,
is
sir.
all of the above. So what do you think? What's the diagnosis and what favors the diagnosis? Yes, go ahead. Start now without wasting the time.
Sir, diagnosis is Cushing syndrome.
Okay.
And
Now tell
what
me
favors?
1 minute, brother, 1 minute, 1 minute. Don't be in hurry. I want to understand and I want to teach everyone. So first off, tell me what makes you to think of Cushing syndrome. Number one.
Yes, sir. So this person, she's a young female, and she's having hypertension with proximal muscle weakness and weight gain in upper body and purple striae. All these are features of Cushing's disease because there will be high level of cortisol. Now, high level of cortisol will cause hypertension and weight gain because this will indirectly cause weight gain because cortisol is a stress hormone, and there'll be hypertension also. And seeing purple striae is a feature of Cushing's disease, sir. So this is the reason why I chose Cushing's
Okay,
disease.
fine, fair enough. So you answered the one questions very well. So this by scenario, irrespective of the questions, right? So female hypertension, proximal weakness, weight gain, purple stripe, you feel this is a Cushing syndrome. Now go to the next things, right? So when you are suspecting anybody as a Cushing syndrome, right? So how you diagnose? Number one is how you diagnose the Cushing syndrome, right? And second thing is how you get to know the etiology of Cushing syndrome, right? So there are two other questions. So what do you think? What's their question? Now let's move to the next question. Which of the following test gives a clue about etiology? They are interested in etiology of most probable diagnosis. By you, most probable diagnosis is Cushing syndrome, right? So
Yes,
your most probable diagnosis. So how do we get to know the etiology of Cushing syndrome by selecting any of these tests? You understand my question or not yet?
yes, sir. Yes, sir.
Right. So now you select. What do you think that which test will give you the idea about the etiology of Cushing?
So etiology means like the origin, like which gives us the clue towards the disease. Like in all these tests, we will know the cortisol level of that person. So if they would have asked which is the most definite, the gold standard, then I would have chosen dexamethasone suppression test. But since they have asked etiology, I think all these tests, midnight salivary cortisol, low dexamethasone
Fine,
suppression
fine,
test, everything would have
fine. So let me come to the next point just to clarify you. Right. So all of the tests, say for example, all A, B, C, D, all tests are help to get the etiology, right? So say for
Yes.
example, I did a mid salivary test, cortisol level, and it is high, right?
Mm.
Then what could be the cause of Cushing syndrome?
Uh,
You understand my question? These all tests will give you the idea about the etiology of your probable diagnosis. So, if the high mid salivary cortisol level, what is the etiology? If the low dose dexamethasone test is positive, what is the etiology? If the 24 hours urinary cortisol is very high, what is the etiology? And if the high dose dexamethasone test is high, what is the etiology? Now you tell me.
okay, sir. So, uh, if the salivary cortisol level is high, it means that there could be a malignant cause of Cushing's disease, which is causing high level of cortisol.
How do you know that there is a malignant cause in the salivary? If the salivary cortisol is high, it could be high in all on any etiology. If it is from the brain, it is from the adrenal, it is from the ectopic, right? So it could be anything, isn't it? So how do you get to know that if somebody done my tomorrow morning test or midnight salivary cortisol of Dr. Munjal Pandya is very high tomorrow, right? In a midnight salivary cortisol, then where do you think where is the problem in Dr. Munjal's body? In the brain, in the adrenal, in the ectopic, where is the problem? Because they know the etiology, they are interested not in the diagnosis, they are interested in the etiology, right?
Mhm.
Of probable diagnosis. So probable diagnosis you already made it, right?
Mhm.
So for this probable diagnosis, right, what could be the etiology? Anyone, now it's open for all, anyone.
Sir, also it could be that person is under extreme stress, and at that spurt of moment, the salivary cortisol seems very high because it is a stress hormone.
Yeah, I'm absolutely agreed with you. What do you mean by etiology? Tell me, first of all, tell me what do you mean by etiology? Etiology means what?
Etiology means, sir, origin, the cause, the
Origin.
genesis.
Okay, the cause, etiology or cause of the Cushing syndrome. So what do you, so how do you get to know by mid salivary cortisol level that where is the origin or what is the cause? I'm giving you the one example, na, that okay, this patient comes to you, you suspected Cushing's, you did a midnight salivary cortisol, and I'm telling you the result as well that okay, it is high. Now tell me where is the cause? This is the test. It is not the cause. Mid salivary cortisol is the test, right? It is not the cause,
Yes.
right? When you are suspecting anemia and hemoglobin is low, it is the finding. It is not the cause. What is the cause? Iron deficiency anemia cause, sickle cell anemia cause, dimorphic megaloblastic is the cause, pernicious anemia is the cause, GI blood loss because of colon cancer is the cause, right? Or etiology, right? So CBC is not the cause. CBC is the finding. It's the test. Mid salivary cortisol is the test. Low dose methazone is the test. So by doing which test you get to know that what's the etiology? Fine.
Sir, that is
Anyone
low
wants to try?
HbA1c.
Anyone? I mean, just it's a discussion. I mean, if you discuss, I would be glad. Yeah. Anyone? Dr. Ashok, Dr. Manjit Singh,
Yeah,
Arun,
I would like
Ajdani. Anyone?
am I
This is a
clear?
100%. This questions comes in exam. Yes, Dr. Ashok. Want to comment on this?
Yeah, I would like to try on this.
Yeah, try, sir. We are
I
not in hurry.
I'm
This is absolutely
I'm
discussion
hearing
platform.
echo. There is a lot of echo is coming from. I think Manjit Singh's mic is also on, so and okay,
No
it's
problem.
clear
You
now.
can chat with me in the chat box. No problem. So anyone, we are more than 20, 30 doctors in the platform. So if
Yeah, sir.
anybody wants to,
Firstly, okay, sir. I will comment a few sentences on this. So just from the information given in the question, so we can just say that this is a Cushing syndrome. But whatever I know, uh, in the Cushing syndrome, we have to evaluate. Actually, we cannot reach directly to a point with any of the tests. Firstly, we perform the three tests, like we can do 24-hour urinary cortisol, we can do low dose dexamethasone suppression test, we can do midnight salivary cortisol. So out of these three tests, so if any of the two tests are positive, so it just indicates that the cortisol level is high. So after that, we proceed further to confirm the source of the cortisol. It can be exogenous, some tumor might be producing, adrenal gland might be the problem, or pituitary or hypothalamus might be the cause. So
okay,
after that, we proceed further. We give the hydrodexamethasone test, and then we come to know whether it's an exogenous. Like we follow the flow chart of this Cushing syndrome, and then accordingly we can
fine.
know
So
the cause of
what's
the
the
Cushing
final
syndrome.
answer from your side? By doing what test you get to know the etiology of this Cushing? Final
Uh,
answer from ABCD from your side?
I think we can do any of the tests we can do. At this point, I cannot say that I would choose E, all the above.
Fine, fair enough. So those who did not answer at all the questions, first of all, once my lecture is finished, my humble request, I am doing lots of hard work for you guys for last years and years, right, to just deliver you the good lecture. So it's your equal duty to go and read Cushing's and Addison's, both the disease, from first line to last line. Three things concentrate: how you diagnose both the disease, Cushing's and Addison's, how you investigate, what is the initial test, what is the base test, and what is the treatment. I will take a picture of the people who attended this class, and I'll definitely ask them personally. So if you cannot ask, then I won't be happy, right? So I'll take right now the picture, those who are attending the class, right? So I will ask each and everybody personally tomorrow, right? Or drop the message, and I will ask the questions what they have read, right? So it is very frequently questions, asked questions, and it is 200% comes in exam, right? So let me tell you first of all the basic things, right? This is a Cushing's disease. So let me tell you, this is the simple diagram I'll probably draw for you, right? So no need to mug up. I mean, if you little open up your mind, you get to know, right? Cortisol is a normal hormone in our body. Cortisol, if the cortisol is high, the word is hypercortisolism, hypercortisolism. And if it is low cortisol, it is called hypocortisolism. Simple. Hypercortisolism we called as a Cushing syndrome, that is hypercortisolism, low cortisol, hypo or Addison's disease. Simple, right? So just try to understand. I mean, it is not rocket science, right? So Cushing syndrome, there is a hypercortisolism. This is a hypocortisolism. So how you diagnose the hypercortisol? So when there is an increase, 24 hours urinary cortisol is very high, you can suspect that okay, it is hypercortisolism, right? Or midnight salivary, if it is high, you can say it is a hypercortisolism. If you can measure the plasma cortisol, if it is high, it is called as a hypercortisolism. And same way the Addison's disease. So this is a simple way by which you get to know that okay, fine, it is hyper or hypocortisolism, right? And as rightly mentioned by Varun, that what are the symptoms is increase the weight, right? Stria on the body, right? Also there is a hypertension, right? This is mainly the female, right? So these are the few things where you suspect hypercortisolism or hypocortisolism, right? So this is one thing. So that you must know. Second thing is between these three thing, there are lots of questions asked in the exam. So now first of all, what you need to know this is hypercortisolism or hypo. So here, if you can match, it is hypercortisolism. So your diagnosis is made Cushing. Now what they ask exactly, which of this test give you the clue about the etiology, means where is the problem, right? So before that you need to know, right, what are the possible cause of this Cushing syndrome. So when there is a Cushing syndrome means hypercortisolism, there must be some brain tumor. So brain tumor or pituitary tumor. So if you have pituitary tumor, it increases the more ACTH, it increases the more cortisol, and patient have hypercortisolism and Cushing syndrome. So this is etiology. So etiology is where it is in the pituitary. It could be ectopic. Ectopic, the commonest ectopic is a lung paraneoplastic syndrome, small cell lung cancer, we'll discuss, right? So there are small cell lung cancer which releases the hormone like ADH, antidiuretic hormone, and ACTH. These are the two hormone it is released from the tumor of the lung cells, and this ACTH release is present like cortisol, increased cortisol or hypercortisolism, but this is secondary, right? Secondary to the paraneoplastic syndrome. So tumor in the lung, but if you see the 24 hours uric cortisol level, patient present like Cushing syndrome, but disease is in the lung, so you need to evaluate, right? So this is called ectopic. Another is adrenal. What is adrenal? Just above the kidney, there is a gland called as the adrenal gland or suprarenal gland. This suprarenal gland is differentiated in adrenal cortex. It is outer layer, right? So this is adrenal, right? So this is outer layer is cortex, and inner layer is a medulla. So outer layer cortex is what they release cortex, glucocorticoid, mineralocorticoid, and sex corticoid. Probably you forget the physiology, but go and read it. Very interesting. So you don't need to mug up. So cortex releases this glucocorticoid, mineralocorticoid, and sex, and right, and medulla what release noradrenaline and adrenaline, right? Fight and fright hormone, right, which controls the blood pressure, right? When there is hypotension, we start NORAD, start adrenaline, right? So when there is a hypercortisolism, glucocorticoid, mineralocorticoid, sex corticoid depends this activity is need. Glucocorticoid increase, sugar is increased. Mineralocorticoid increase, blood pressure increase. Sex corticoid, this all androgen derangements, all symptoms, tria, weight gain, like that you can see, right? So these all are the etiology. So etiology could be either in pituitary, it could be ectopic, it could be adrenal, or it could be exogenous. Exogenous corticosteroid means what? We are giving steroid directly to the patient, right? We are giving steroid to the patient. There are lots of patients, those who are on steroid because of skin condition, autoimmune disease, multiple connective tissue disorder, and there are long list, right? So these are the possible cause, right? So now how do you get to know, by which test you get to know? So this is the things. Now see, this is excellent schematic chart. I brought it for you. So you don't need to mug up, right? You need to just understand. So this is called dexamethasone suppression test. What is that? Simply understand. So you give the dexamethasone is a steroid. Dexamethasone is a steroid, right? So if you give a dexamethasone to a patient, right, there are two possibility, right? And in dexamethasone there are two entity: low dose dexamethasone and high dose dexamethasone. So first you go on the left side, low dose dexamethasone. So what it cause when you give any patients a dexamethasone, especially low dose, and you check the cortisol. If the cortisol is going down, right, after giving the dexamethasone, low dose, if the cortisol is going down, that means it's a normal person. So consider yourself. Think in that sense that tomorrow, if somebody gives you the dexamethasone low dose and if they check your cortisol, if it is normal, then right, if it is low, sorry, then you are a normal. What happens if somebody has given the low dose dexamethasone and still the cortisol is high? Still the cortisol is high. It does not get suppressed. Suppression is not possible, right? In that case, it is called as a Cushing syndrome. So simple. So now any patients comes to you in your OPD, you are suspecting Cushing syndrome. You are suspecting just that okay, this guy could be. I'm not telling you 100%. Could be a Cushing syndrome. What you do? You give low dose dexamethasone. You check the cortisol. If cortisol going low, normal. If cortisol cannot get suppressed because there is a high level of cortisol, does not get suppressed. Means it's a Cushing syndrome. That's it. So this confirm this low dose what it confirms. So, right. So here, let me tell you here the low dose. So low dose will confirm whether there is a Cushing's or not, right? Low dose, if you give low dose dexamethasone, there are two possibility. If there is a suppression, it is a normal. If it is no suppression, still cortisol is high, it is called Cushing syndrome. That's it. So this will tell you the low dose dexamethasone tell you whether Cushing syndrome is present or Cushing syndrome is not present. Once you confirm the Cushing syndrome is present, then the next step will come, which is on the right side. How it comes? Once you confirm that okay, Cushing syndrome, then what's your next step is what's the etiology? So this second part, this second block will is this is for whether it is Cushing syndrome is present or absent. Once it is confirmed it is present, then what is the etiology? And etiology will tell you by the high dose dexamethasone. Same story. Don't no need to hear low dose dexamethasone, here high dose dexamethasone. What happens? Here the cortisol low and high, here the same cortisol low or high. If you give the high dose dexamethasone and cortisol gets low, that means it is a Cushing's disease. So what is the difference between Cushing syndrome and disease? Cushing syndrome and disease. Cushing syndrome is a cluster of the symptom. There it could be any reason, while Cushing's disease is hypercortisolism because of pituitary only. Pituitary. So if you have pituitary adenoma, if you have pituitary tumor, right? In that case, what happens? Some patients has pituitary, they present with the Cushing syndrome. So first, what you do? You give dexamethasone, right? You give low dose dexamethasone, and right, and if you measure the cortisol, it is high. So you fix her. Please make mute and Cushing syndrome. And once Cushing syndrome is confirmed, then you give the low dose of cortisol, right? If you give the high dose of dexamethasone and cortisol gets low, it's a Cushing disease. And still, even with the high dose of dexamethasone, it does not get suppressed. Still, the cortisol is high. Then you do ACTH, whether low or high. If ACTH is low, it is
ആ
adrenal,
റൂം
and if it is
വൃത്തിയാക്കുന്നുണ്ട് ഇവിടെ
and high
ഇതിലില്ലേ ആ
ACTH.
ടേബിൾ ഒന്ന് ഇടിച്ചിട്ടായിട്ട് തൽക്കാലം മറ്റേ ഇതില്ലേ എന്തിനാ പറയുന്നത്
So this is what the thing is, right? Is that clear, Varun?
Sir, it's clear.
Varun.
Yes, sir. It's clear.
So keep this chart in mind. It is not very complicated. You need to just simply remember on the left side, you just need to know that what is the whether patient has a Cushing syndrome is there or not, right? Either normal or Cushing. Once you confirm the Cushing, go to the right side. So Cushing confirmation can be done by low dose. Once you low dose, you confirm, then you give the high dose. Again, repeat the same thing. What happens to cortisol, low or high? And if it is high, then do the ACTH. If ACTH is low, it is adrenal. If it is ACTH is high, then it is ectopic like lung, right? So this is very, very extremely important questions in exam. So once you go and read it, I think you have lots of confusion in your mind that what is the Cushing syndrome and what is the things, right? So this is extremely important test. 100% either they ask you low dose or high dose or various complexity. But if you understand this chart well, right, I don't think so you have any problem understanding any questions related with the dexamethasone, low dose or high dose. Is that clear?
Yes, sir.
Is that clear, Varun?
Yes, sir.
Yeah. So that's it. So this is all the schematic presentation. So you just evaluate. I will upload this PowerPoint and this video as well at the end of the session, right? So this is extremely important, and this is all the treatment is given here very well, right? What happens if there is a pituitary tumor? So you go through it, right? Nothing much critical, all right? So just to cut short the time. Second questions in front of your screen. 89-year-old male with past medical history of metastatic lung cancer, status post chemotherapy, present with the headache. Present with the headache. Yeah, so 89 years old male with past medical history of metastatic lung cancer, status post chemotherapy, present with headache. On examination, he has worsened the pain when lying down. On imaging, CT head shows a brain abscess. You can see this is all round is a brain abscess. Diagnosed as a nocardia. So ultimately diagnosed as a nocardia by biopsy. What is base treatment for nocardia? Treatment with trimethoprim and sulfamethoxazole, treatment with doxycycline high dose, metronidazole and ampicillin, or I mean, it's all are this treatment for this, all effective. Post your answer. Fine. So most of the people had given the correct answer. It's a treatment with trimethoprim and sulfamethoxazole, right? So I would like to have one volunteer who can tell me what other indication where you can use the sulfamethoxazole and trimethoprim. Give me at least three, four indication. One is nocardia, where you can use trimethoprim and sulfamethoxazole. Anyone can tell me what other clinical indication? They may ask you some other uh, questions as well. Okay, so UTI, cystitis, pneumocystis, lung abscess. Fine, fair. So a lot of answers. So basically, lung infection, urinary tract infection, right? Even some skin infection you can use. So it is a very nice antibiotic. So so answer is a yes. That's the correct answer. Trimethoprim and sulfamethoxazole. This is all round, white, right, ring shaped, clear cut, well demarcated lesions. These are the brain abscess, right? So consider tissue sampling for the diagnosis if no pulmonary lesions are identified, right? And treat with the trimethoprim and sulfamethoxazole. Sulfamethoxazole and trimethoprim in combination in used in treatment of urinary tract infection, middle ear infection, otitis media, bronchitis, pneumonia, traveler diarrhea, shigellosis, bacillary dysentery, and long more, right? So these are the long list. So this also you should keep in mind, right? So great, that's it. Let's move to the third question. 55-year-old woman present to a gynecologist complaining of vaginal discomfort. It first started approximately 6 months ago and had fluctuated in the intensity, most recently causing itching and some slight pain when she has a intercourse with her husband. She otherwise has been well. She has been postmenopausal for 3 years. Her older sister recommended an estrogen cream, which she has used consistently for more than 3 months without any changes in the symptoms. On examination, the introital mucosa and labia minora are whitish pink with abnormal wrinkling and small fissure on the right labia minora. Which of the following is most likely diagnosis? If you want to see the picture, they will give you the picture in the exam. This is the picture of the description. This is how it looks like. This is the questions. If you wish, you can read it once again in your mind and try to post the answer. So what they are asking is what's the most likely diagnosis, right? So here I ask you the three questions. What is the most likely diagnosis? Yes, that is one question. Second question, how to confirm this diagnosis? Second question. Third question, once you diagnose, what is the best possible treatment for these things? So that's it. Post your answer. Yes, Dr. Abhishek, any comment? Dr. Abhishek, Dr. Venk, Venk, Venk. Yes, anybody. Anybody wants to try this question? If the same questions comes in exam, how you supposed to answer? So how, Dr. Ashok, you can differentiate lichen planus with the lichen sclerosus?
Sir,
How can you
the
differentiate?
one starting point that differentiates between the lichen planus and sclerosis is that lichen sclerosis does not involve the
Your voice
introitus.
is bit
Vaginal
low,
introitus.
sir. Can you make your mic a little bit closer like me so everybody can loud and clearly listen your expertise?
Sorry, I'm raising my voice. Uh, is it audible now?
A little better, not much.
Okay.
Anyway, Dr. Hina, any comment? Dr. Hina, how you differentiate between lichen planus and lichen sclerosus?
Lichen plants, I think it is on affecting surfaces like flexure, palm, soles.
Okay, so
I
what's here
think
the diagnosis? It's C or D or A?
Am
Candida.
I clear now, sir?
Yeah, very much clear now.
D, D. It could be D.
It could be D. Okay, fine. So let's Dr. Ashok comment. Yes, so Madam
So,
Hina is saying it's a D. Now
okay.
we can
Most
discuss.
probably, I also think it's a D only because lichen planus, it involves the vaginal introitus. And the
Okay,
one striking difference is the same that lichen sclerosus does not involve the vaginal mucosa. It just involves the mesura, minora, and there will be thinning, like the skin will be papery, thinning white, or it might involve the anal area also, like the
oh,
superficial vagina, labia minora, mesura, and anal area. In the pattern of the figure of 8, it involves lichen sclerosus.
excellent.
Okay,
So
correct answer is lichen
this is
sclerosus.
yeah. So
Okay.
lichen sclerosus is also called as a lichen sclerosus at atropicus is the most common in postmenopausal women. So our patient is a postmenopausal. So everything in scenario is very important, right? So she is a postmenopausal woman. They have mentioned postmenopausal for 3 years. So always concentrate on the history, right? There is something clue. So postmenopausal woman cause itching of the anogenital region. However, it can also occur at all ages and both sexes can be found anywhere in the skin, on the skin, anywhere on the skin. What is the etiology? Though the etiology is not known, but chronic inflammation is thought to be play a main major role in causing the labia to become white, brickled, and fragile, right? And definitive diagnosis can be done by biopsy. That almost all the doctor has given the good answer, and the treatment is the ultra potent topical corticosteroid applied daily for several weeks, right? And lessen the frequency in long term, right? So that's it. So this is what the lichen sclerosus. So don't get confused with the lichen planus and lichen sclerosus. So they may give you some pictures as well. This is a picture MCQ. So it's a very interesting questions, right? So keep in mind. Let's move to the fourth. Very nice interactive MCQs where you can use lots of analytic skill in this. 37-year-old woman present to her physician with 3 days of fever, fatigue, rash. Her medications includes oral contraceptive. Her temperature is 38.7, 101 Fahrenheit. She also has non-palpable petechial rash and splenomegaly. Coagulation studies and fibrinogen levels are normal, but a complete blood count shows a hemoglobin of 9.7, platelet of 135,000. A peripheral smear shows schistocyte. And which of the following is most likely diagnosis? So I need diagnosis, I need investigation, I need treatment, I need all triad. But first of all, diagnosis. So is it DIC? Is it HELP, hemolysis, elevated liver and low platelet syndrome, Hanos-Collin purpura, or HSP, idiopathic thrombocytopenic purpura, or ITP and TTP, thrombotic thrombocytopenic purpura? So you can apply all your analytic and hematology skills here, right? And I need whatever the answer you are giving, I will discuss that why you selected this, why it is not ITP, why it is not HELP, why it is not DIC. Yeah, post the answer. Just I got a two answer. I mean, we are 30 people, and we get a just two answer. So don't think that you need to give me answer. Think that if the same questions comes in your exam in front of your screen, what will you gonna answer this? Who is AC? I don't know this name. AC. Somebody joined as a AC. Yes, I'm waiting one more minute because I need answer. We need only three answers, and we are 30 people in the house. So if you don't give the answer in the exam, that is gone. So give at least some answer. Think what it could be, right? Because this is not a very difficult question. Na? You try to compile all the questions, laboratory, everything. Yes, Dr. Asmat Dennis, do you have any comment? Now I will tell by the name, so you get activated. Yes, Dr. Asmat Dennis, what's the diagnosis? Dr. Neha, Dr. Neha, what's the diagnosis? Dr. Kiran, what's the diagnosis? Yes, doctor. How it is ITP, Dr. Hina? Can you unmute your mic and discuss?
आईटीपी में आई थिंक हेमोग्लोबिन डिक्रीज होता है आई थिंक ब्लीडिंग
Oh,
के
so
चांसेस भी होते हैं
I got it.
तो इसलिए
So I will interpret in English as well for other students. Don't worry. So मैं ये समझना चाहता हूँ कि इसमें हीमोग्लोबिन क्या होता है, आईटीपी में क्या होता है? What happens to the ITP? What parameters
Doesn't
reduces in the ITP?
doesn't
Is
change.
the hemoglobin reduces in ITP? Yes or no?
यस आईटीपी में हेमोग्लोबिन डिक्रीज होता है
नहीं होता है. It's not reduced. So your first and foremost thing is to go and read the ITP complete chapter. I will ask you in the evening, right? So read the ITP. Only read the ITP today. ITP, idiopathic or immune thrombocytopenic purpura. We will discuss in detail today evening. I will not go around and enjoy my Sunday. We'll discuss. Yes, Vank.
ओके
Any Vank doctor is there? Vank, VENK, Vank. Dr. Neha, Dr. Abhishek, Dr. Ajdani, Dr. iPhone, Dr. Zainab Ali Hassan, Dr. Kiran, Tariq, Mozam, lots of doctors, no answer. Anyone?
It's most probably an TTP because there are patterns like the patient has fever, anemia, thrombocytopenia. There is rash as well, and there is microangiopathic hemolytic anemia type of presentation is there because the peripheral smear shows the cystocytes. That is the searing of RBC whenever there is a thrombus present inside the microvasculature. So RBC gets seared. So this is a typical classic presentation of TTP. So we
Okay,
have to differentiate it from the hemolytic uremic syndrome, which is not in the option. So it's become easy also. And
okay. So
Hus will be
if it is a hemolytic uremic syndrome is also in the option, what will you select?
if Hus is also in the option, so most probably still I have to go with the TTP only because in Hus, some precipitant like bloody diarrhea history should be there, like Shigella, enterohemorrhagic E. coli. These infections should be there, and in the TTP, there will be much of the if it will be provided, then there will be much of the neurologic sign like confusion and neurologic sign and symptom will be there in the TTP. Where in HOS, there will be much more of renal complications like renal presentation. There will be raising the creatinine level as well. So
Mm-hmm.
with these findings, I think we can
Fine.
differentiate.
So now I will clarify. The answer is TTPS. Let me tell you. I mentioned six things here, and this is all six complicated and confusing. First is HSP. Just if you remember this, na, just to make this chart, I took 20 years in hematology just to make this chart, right, for you. That is a simple chart, but all the things will get sorted out. HSP is Henox calling purpura. It is vasculitis. It is vasculitis and platelet count is normal. So story is over here for HSP. Remember the scenario, platelets are low. So when the platelets are low, it is not HSP. Platelets are 13, right? So what is the normal platelet count? 150,000 to 450,000, and this is 135,000. That means what? Platelet counts are low. So what is the first scenario I told you? Whenever you see any HSP, how the HSP present? It is present usually in the children, right? It's an autoimmune disease. It's a vasculitis where the platelet counts are normal. So when platelet counts are normal, it is not HSP. Is that clear? Yes or no? At least tell me yes or no. Yes or no. Yes or
Yes.
no. Right?
Yes.
So HSP is not there. Why? Because platelets are normal in HSP. In this scenario, it's low. So it is gone, HSP. Now come to second point. ITP, what happens to platelet? Platelet counts are low. Platelet counts are low. Hemoglobin and WBC are normal. It is a isolated or immune thrombocytopenic purpura. So ITP is a condition where you get everything low, everything normal. What normal? Everything normal means what normal? Understand this. Everything normal means low platelet count, HB normal, total count normal, no lymphadenopathy, no hepatosplenomegaly, bone marrow biopsy normal, chest X-ray normal, USG normal, HIV, HBsAg, HCV normal, all viral marker normal, no drug history, no thing, everything is normal. What does it mean? Only platelet counts are low, and that is why we call it as a diagnosis of exclusion. Diagnosis of exclusion is ITP. So you ruled out all the condition HIT, TTP, heat, HUS, leukemia, lymphoma, myeloma, aplastic, DIC, long list. Nothing is there, then it is ITP. Is that clear? Yes or no, Dr. Hina? So here the platelet counts
Yes.
are low, hemoglobin is not low, it is a normal, right? So here go back to the scenario, platelets are low, hemoglobin is also low. 37 of year of woman, I expect at 37 it should be at least 12.5 grams of hemoglobin in a non-pregnant woman. Instead of 12.5, he is close to 9.5. So 3 grams low. It is a mild anemia. It's a mild anemia. It's not a normal, right? And she also has a cystocyte. So I will explain you each and everything in this department. I'll explain you, right? So second, go to the second. So why not HSP in the thing? Because platelets are low. In HSP, platelet should be normal. Why not ITP? Because in ITP only low platelet, but in our scenario platelet is low, hemoglobin is low. So again ITP is not there, right? HUS. What do you mean by HUS? The full form of HUS is hemolytic uremic syndrome. Please make your mic mute, madam. Hemolytic uremic syndrome. So this is again very much confusing to lots of doctors how you differentiate HUS and TTP. So let me tell you very easily hemolytic uremic syndrome and TTP. So it's a simple, nothing critical, right? So HUS is usually seen in the children. HUS three things: low HB, low platelet count, and increased serum creatinine. Uremic means something wrong with the kidney. Simple, no need to mug up. Hemolytic. When there is a hemolysis, there is anemia. So HB is low. When uremic, something creatinine is low. Hemolytic uremic syndrome and uremia usually platelet counts gets down. So this is the things in HUS. The same three things is there in the TTP. Hemoglobin is low, platelet count is low, increased serum creatinine. Then how do you differentiate? This is called as a triad. This is called HUS triad. HUS triad, and this is called TTP pentad. Pentad, PENTAD. Pentad means five things. So these three things, fourth thing is a fever, and fifth thing is a neurological involvement. Neurological involvement. So this is pentad, right? So there are five things, and fever is one of the most striking features in TTP, which is there in our scenario. Go back, go back. Fever is 101.7, 101.7, right? Which is not usually in, you can see in HUS, it can be seen in TTP, right? Fever is there, fever is there. So fever is also there. HUS is seen in children. This is 37 is not children, it is young adult, right? So it is seen in more in elderly or middle-aged patient, right? So here, let me go little further. I want to make sure that you understand this third last category, DIC as well. So DIC, what happens? DIC is a disseminated intravascular coagulation, right? So what are the causes? Either pregnancy, missed abortion, snake bite, sepsis, right? Occult infection that lead eventually to DIC. So what happens to DIC in CBC? Usually platelet counts are low. It is called as a consumptive coagulopathy. This is the book word, consumptive coagulopathy. So platelets are utilized and factors are utilized. Means PT and APTT will high when there is low factor. So they both will increase. So platelet is low, PTT high because of clot. Fibrin are also going very down, so serum fibrinogen is also down, right? Which doesn't looks to be in the scenario. Did they mention anything about PT and APTT? Not mentioned. And when something is not mentioned, means considered it is a normal. When something is not normal, right? Here the blood pressure is not normal, diabetes not normal, sugar not normal, means considered it is normal. They have not mentioned serum creatinine. Consider that this is normal. Not mentioned means normal. Think in that way in exam, right? So PT and APTT not mentioned means normal. So PT and APTT cannot be low, cannot be normal in DIC. So disseminated intravascular coagulation is almost gone. Why gone? Because PT APTT is normal here. Hemoglobin never fall or usually don't get fall in the DIC, right? It has nothing to do with the hemoglobin, it has to do with the platelet and prothrombin. I mean, right? Clotting factors. HELP syndrome, hemolysis, elevated liver. So, can you see this is the full form? Hemolysis, elevated liver, right? And low platelet, right? HE means hemolysis, elevated liver and low platelet. So hemolysis is there. It could be hemolysis. You can see in hemolysis, right? If it is DIC, fibrinogen should be level should be low. Here the fibrinogen should be low. Here it is normal. So again DIC is not there. Why? So hemoglobin is low, which is not there in DIC. PTPT should be high. It is not there in scenario. Fibrinogen should be low. It is normal in scenario. So DIC is gone. Hemolysis, elevated liver and low platelet. So low platelet is there. Hemolysis could be there. How come you know hemolysis? Because there is a low hemoglobin and there is a cystocyte. But do you think there is an elevated liver enzyme? So there is no elevated liver enzyme. Liver enzymes is not mentioned at all in this scenario. So DIC is gone. HELP is gone. HSP is gone. Why HSP? Because in HSP platelet count should be normal, where here in this scenario it is low. So it is not HSP. Idiopathic thrombocytopenia is not there. Why? Because in ITP there is only low platelet. But here along with low platelet there is low hemoglobin, fever, blah blah, which is not matching ITP. And why thrombocytopenic purpura? Because TTP, usually the young male female present with the fever, neurological symptoms, low HB, low platelet count, right? High creatinine, and because of this is a micro angiopathic hemolytic anemia, you get a cystocyte. Cystocyte is what? I did a lot of exercise and try to make you understand what is cystocyte just to get you the idea what is cystocyte. So this is normal RBC. Normal RBC is a dumbbell shaped. This is the up and down picture, and this is side by sound picture. So this is a normal red blood cell. This is like normal red blood cell, and this is the cystocyte. This is cystocyte, or another name is a fragmented RBC. Fragmented RBC. Another thing name is a broken RBC. So when you cut like with the sword, if you cut half the RBC, it looks like this broken RBC, right? So this is the broken RBC, and that can be seen as a cystocyte. Cystocyte. Cystocyte means what? Broken RBC. So this is seen in the peripheral smear. If you take a blood in the EDTA, make a slide, so if it is a normal, it looks like normal. If it is cystocyte, it looks like this. So in what condition the cystocyte can be seen? TTP, cystocyte, microangiopathic hemolytic anemia. HUS, hemolytic uremic syndrome. DIC, mechanical prosthetic valve. mitral valve replacement, malignant hypertension, in sometimes in the burns patients, metastatic carcinoma, HELP syndrome, congenital RBC defect like hereditary spherocytosis, sometimes sickle cell disease. These are the few conditions where you get the cystocytes. So there are long list of differential diagnosis of cystocyte, but in context to these questions of MCQ, this is most fitting the hemolytic uremic syndrome. My talk is over. Any question? I try my level best to make you understand. This is the most simplest form I can make you understand. Dr. Ashok, is that clear? Hina?
जी सर, आई एम क्लियर।
तो अभी आपको गलती नहीं होगी एग्जाम में, कोई भी प्लेटलेट कम आए तो
इंशा
आपको गलती नहीं होनी चाहिए।
इंशा
ठीक है, आपको वापस से कुछ भी दिक्कत है तो मेरे को आप फोन कर सकते हैं, बट आई डोंट वांट टू मेक यू द रॉन्ग आंसर इन द एग्जाम। एनीबडी? यस, anybody has any questions? Anybody has any question? Dr. Ajdani, Abhishek, Varun, Ashok, Zainab, Kiran. So now next question for two doctors. Dr. Saba is the next question, and after that, Dr. Utsia Khan. So get ready with your next question. Next question I will discuss with Dr. Saba Imtiaz. Wonderful. Any questions to any house? Right. So this is again the same thing, HUS and TTP. So we'll discuss this. So now let's come to the Dr. Saba will answer this. 48-year-old auto mechanic present to the clinic with complaint of many years of pins and needles in his left hand that initially occurred on while working but have worsened substantially. He claims the pain wakes him almost every night, and physical examination revealed marked weakness and wasting of the left hand muscle. Which of the following is most likely diagnosis? Amyotrophic lateral sclerosis, angina, carpal tunnel syndrome, multiple sclerosis, and myasthenia gravis. Take your time. Don't disclose. Post your answer in the chat box. I can monitor everyone. Hmm. Yes, Dr. Sabha. What do you think? What's the answer? Can you unmute? Yes, Dr. Kiran, I think Dr. Saba is stuck up somewhere. He is posting the answer but unable to discuss. Dr. Kiran, any comment? Yes. Anyone?
It looks like carpal tunnel syndrome.
Sorry, doctor, what do you think? What could be the diagnosis of this condition?
Carpal tunnel syndrome.
Okay, so now you give me the point favor in the carpal tunnel syndrome. Why you selected carpal tunnel syndrome, not multiple sclerosis, not myasthenia gravis, what not angina? Because you need to exclude, like the last question I excluded DIC, TTP, HUS, right? HSP. Then you get complete clarity that why this is not there. Otherwise, it's like a mug up. So now tell me what point favors in carpal tunnel syndrome. Start.
Because it's only in left hand
So it
and
cannot be in the right hand. If this questions mention right hand, then this is carpal tunnel syndrome is not the answer.
yes, it could be.
Yeah. I'm just trying to understand. See, by
All right,
discussing, you
perfect.
will clarify your thought
Yes, I
process.
can
So don't
understand.
hesitate.
No,
Yeah.
no, no,
So
it's okay. It's
yeah,
okay.
so you need to put your completely clinical knowledge in this scenario, that why this not ITP, why this not HUS, like the way I explained in detail in last question, right? So now complete clarity. So you need to know first of all what is amyotrophic lateral sclerosis. Do you know? Yes or no? Tell me yes or
No.
no. No. So your homework after finishing this class is to know amyotrophic lateral sclerosis. I don't want
All
you
right.
to do the PhD, but just read it. It is a common questions again asked. So last mock I had taken one MCQ with amyotrophic lateral sclerosis. Fair enough. Do you know what is
Okay.
multiple sclerosis?
Yes.
Yeah, tell me what is multiple sclerosis?
So not in that much detail,
So second
but
homework is to read the multiple sclerosis. And
all
third
right.
question is to read the topic myasthenia gravis. So today's your homework is to read the three topic amyotrophic lateral sclerosis, multiple sclerosis and myasthenia gravis because
Right.
these all are the very extremely high yield neurological questions in exam. So I don't want you to miss, right? Now tell me why it is carpal tunnel. What exactly happens in carpal tunnel? Radial, medial, ulnar, which now gets affected in carpal tunnel?
Medial nerve get affected and
Medial nerve get
it
affected.
becomes
Okay, so name of the nerve is medial nerve. What level? At finger
yes.
level, wrist level, elbow level, or shoulder level it gets affected?
At
Four
wrist
options.
level,
At wrist level. So second answer is also correct. Median nerve at the level of wrist level. What happens to the medial nerve in carpal tunnel? What happens?
it gets trapped.
Sorry,
Gets trapped.
it's trapped. Strapped because of what strapped? What causing it strapped? What are the causes of carpal tunnel syndrome? What are the causes of
Obesity.
carpal tunnel? Obesity. Give me at least five causes. There are 20 causes, but give me just five. One is obesity. Second, fine. So if you don't know, fourth is to read the carpal tunnel syndrome as a whole as well, right?
Okay.
So for today, your homework is this four. Let me
All
tell you
right.
quickly, multiple sclerosis and myasthenia gravis. We lots of doctors are confusing and they don't know the basic difference. So basic difference in multiple sclerosis is a sclerosis means sclerosis of the nerves. So chronic, progressive. It's not acute. It is chronic for long time. Gradually, progressive degenerative disorder of CNS means central nervous system characterized by demyelination of disseminated means widespread is a disseminated like DIC disseminated intravascular coagulation disseminated means widespread so chronic progressive degenerative disorder of the CNS characterized by disseminated demyelination of nerve fibers of the brain and spinal cord. So central nervous system includes brain and spinal cord. So in brain and spinal cord, there is a demyelination. There is a myelin sheath. If you can see the nerve, there is outside, like in our body, outer structure is a skin. So same the nerve has a skin and it is known as a sheath or it is called as a myelin sheath, right? It's a protein. So there is a demyelination. That myelin is gone, right? Insulation is gone. So there is a demyelination of the nerves in brain and spinal cord. This is the multiple sclerosis. Exactly opposite is myasthenia gravis. It is not a neurological disorder. Let me tell you. It's an autoimmune disease affecting nerve and muscle, neuromuscular junction, right? So myasthenia gravis is a disease of neuromuscular junction primarily. Multiple sclerosis is a primarily disease of CNS with brain and spine where there is a demyelination. In myasthenia gravis, there is at all no demyelination. Myelination is absolutely normal in brain and spine. So where is the problem in myasthenia? Myo means muscle. Remember in that way, myasthenia gravis is a muscle, so it's a disease of muscle and neurons. So neuromuscular junction, right? It's not a brain disorder. Brain functions are normal in myasthenia gravis. It's a movement problem. So characterized by the fluctuating muscle weakness and fatigability. And disease may be generalized or ocular specific. That's it. So this is basic difference. But I want you to go and read Dr. Kiran, right? And what is the carpal tunnel? So this is excellent picture. This is a hand. This is median nerve is compressed at the wrist, resulting in numbness, pain, tingling, burning, blah blah. This is all the consequences. So where this blue part is given in the picture, where it's all now supplied, right? So median nerve gets affected. And what's the things? Mechanic has sign and symptoms of carpal tunnel syndrome which is entrapment of the median nerve characterized by pain, paresthesia in medial portion of the palm radiate proximally to the forearm. Carpal tunnel syndrome often present as a work-related illness. It's a very important clue point, work-related, right? So can you see the automechanic? Automechanic, why it's specifically mentioned? Because it is a work-related. More you use the wrist joint, more you manipulate disjoint. Carpenter is another person. Carpenter, every time he is like doing with the wood, right? Carpenter. So they may get a carpal tunnel. So remember carpal tunnel, carpenter, right? So it is a it's a it's a it's a carpal tunnel syndrome often present as a work related illness in a person whose jobs required prolonged use of hand and wrist. So they usually get, because more you use, more it gets compressed, more it gets stretched the median nerve, and it gets the symptoms. That's it. So your job is to reduce the tunnel, right? So you do some operative things, right? In acute pain you can give NSAID and steroid, but in long term you need to open the carpal tunnel. Carpal tunnel is just in front of the wrist. You open up, release the pressure on the nerves. That's it. Your symptoms gone. You are fine. That's it. Next question. So your homework, Kiran, finally. And those who do not know all these things, don't think that this is only homework for Dr. Kiran. For everybody, those who don't know what is amyotrophic lateral sclerosis, multiple sclerosis, and diagnosis. I need diagnosis, investigation, treatment for all these three, not just the diagnosis. How you diagnose the multiple sclerosis? What is the best investigation of choice for multiple sclerosis? What is the treatment of multiple sclerosis? So if you don't know, go and read it. That's it. Question number 6. 22-year-old woman complains of dizziness and feeling lightheaded. She works in an office and most frequently experiences this when standing up the toilet. She has never fainted. The patient has lost 5 kg but attributes this to eating more healthy. She has noticed a recent scar on the back of her hand, which has been started to turn very dark. The most appropriate investigation. So this is little tricky. Before jumping on the investigation, you need to know what is the diagnosis. So until and unless you know the diagnosis, investigation and treatment is difficult. So what's my question here? What is the diagnosis? What point favors diagnosis? What test confirms the diagnosis, what is the treatment, and how to confirm the diagnosis. So in one question, I have 4 questions. Yes, Dr. Priya, you can start. I would be happy to listen from you. Unmute your mic and discuss. Dr. Priya.
Addison's disease diagnosis.
Diagnosis is Addison's disease. Okay, fine. So now, first of all, tell me what point favors the Addison's disease. We'll go one by one. In the scenario, what makes you to think of Addison's disease?
Recent scar on the back of her hand.
Okay, so recent scar. Okay,
And
this is the only thing.
hypotension.
Hypotension. Right. So how did you get to know there is a hypotension?
She's
Is it
22
is it
year
main?
and dizziness and feeling lightheaded.
Okay, so
And
dizziness is
she
also the
has,
lightheaded,
yeah,
maybe probably signs of hypotension. Okay. What else?
and she never fainted, so I thought maybe hypotension.
Fair enough. Is there any correlation with the weight loss?
Yes.
Okay. So this all you think that this could be a Addison's disease. So this is your diagnosis. So one question is answered. Say for example, this is what's the diagnosis likely? So it's Addison. What point favors the diagnosis you told? Yet young female, probably dizziness, hypotension, weight loss, recent scar, right? So this could be Addison's, right? Fair enough. What test would you think that this will confirm the diagnosis? Amongst this list, co-syntrophin test, low-dose dexamethasone test, cortisol
Sir,
measurement, urinary free, blah blah.
yeah,
What is the best, most appropriate? They ask the most appropriate. Huh? So concentrate on
co
your mind, most appropriate.
co-syntrophin stimulation test.
Okay, co-syntrophin stimulation. So your answer is co-syntrophin. Now tell me what is co-syntrophin?
It is kind of ACTH stimulation
Okay,
test.
wonderful. So this is kind of synthetic ACTH rather, right? Synthetic
Yes.
ACTH. How does it confirm the things? So you give the co-syntrophin stimulation test. So means you are giving some ACTH, right? So what happens to the patient if they have the Addison's disease?
Cortisol levels, thing.
Sorry.
Increase cortisol levels should be measured.
So what happens to cortisol will go high or cortisol will go low? What happens? So there is some test, na cosintrophin stimulation test. So if you stimulate, if you give like dexamethasone suppression test. So if you give the low dose dexamethasone, right, either it is normal or it is elevated. So if it is normal, I mean reduced, it is normal. If it is not reduced, it is a Cushing syndrome. So like that, if the cosintrophin stimulation test is done, what happens to what happens to steroid level? So you go and read it. That's the thing. Okay, fine. How you treat this patient? Say, for example, you diagnose this patient as a Addison's disease. Then what's the you gonna treat? How you gonna treat this patient?
Forgot,
You
sir.
know that. Okay, fine. This is Addison's, right? So how you gonna treat this patient? What treatment you give?
Treatment I forgot, sir.
No problem. So your homework is to read the Addison's disease completely from first line to last line. Completely, you need to read. I am always interested in three things: how you diagnose the Addison disease, how you investigate the Addison's disease, and how you treat the Addison's disease. They never ask out of these three questions. So you need to know very clear cut. I'm very happy that you answered almost all the questions nicely, confidently, perfectly, right? But still, these are the very high yield questions in the exam. So you must read the Addison's disease as well, right? So we just discussed. I think you were not there earlier in the class. I think so, where we discussed the hypercortisolism or Cushing syndrome. One practical things I would like to give you, right? In Cushing syndrome and Addison's disease, which is very important, and which will give you excellent idea. Cushing syndrome is steroid is increased, steroid or hypercortisolism. Here steroid is reduced, hypocortisolism, right? So here cortisol reduced, here cortisol increase, cortisol, right? Along with this, everything is increased. When the steroid increase, everything increase. What do you mean by everything? Blood pressure increase, right? Sugar increase, sodium increase. Only one thing is reduced is the potassium. This is exam point question. Cushing syndrome, everything will increase, potassium decrease. Here reverse, blood pressure low, sugar low, sodium low. What increases is the potassium. This is a high yield point in exam. That's it. So when there is a low cortisol, everything is low except potassium high. In Cushing syndrome, hypercortisolism, everything is high except potassium. That I want to explain you. So that is why this sometimes is exam question, right? So they may say which electrolyte will, what happens to the potassium. So this Cushing syndrome, what electrolyte disturbance, right? Hyperkalemia, hypercalcemia, hypocalcemia, hypernatremia. Then you are confused. So don't get confused. In Cushing's, everything increase except potassium decrease. Addison's, everything low except one thing is high, that is potassium. Is that clear, Dr. Priya, to you?
Yes, sir.
Yes or no?
Yes, sir.
Wonderful. So, cosintrophin stimulation test. The patient has Addison's disease where the adrenal gland is destroyed. How do they destroyed? There are two common reasons across the globe. One is the tuberculosis, which is more common in Asia and Indian part, and the rest of the world, developing country, autoimmunity. So, some kind of autoantibody develops against the adrenal gland, which kills the adrenal gland, which does not releases the steroid from the suprarenal or adrenal gland, and they give hypocortisolism or Addison's disease. So Addison's disease is destroyed the adrenal gland either by infection, TB, or autoimmunity or autoimmune disease. The reduced cortisol, aldosterone, sex, I told you already, produces a myriad of the symptoms, and this causes a postural hypotension. That is why patient has dizziness, patient has a reduced aldosterone and increase the pigmentation, often in Palmer creases, which is newly formed. That is also in the disease, and there this is because of the elevated MSH, melanocyte stimulating hormone. So you get some skin discoloration, and the other symptoms include weight loss, malaise, and vitiligo. That is also part of Addison's. So what is a cosintrophin? The most specific test for the adrenal function is the cosintrophin test. What is cosintrophin? Cosintrophin is a synthetic. Synthetic means you You manufacture in the laboratory. That is a synthetic ACTH. You measure the cortisol level before and after the administration of cosentropin in a patient whose health is otherwise normal. There should be rise in a cortisol level after giving cosentropin. While in addition, there won't be any rise. This is the difference. So this is called cosentropin uh, test, right? And treatment is more than test. Treatment is more important than the testing in acute adrenal crisis. So whenever you feel that this is acute adrenal crisis, you go and read it. That's it. So this is again a different various chart. I'm not going much in detail, but I will share with you. So you must know the basic how you diagnose, how you investigate, and what is the basic treatment of things. Next question. Last couple of questions. During the consultant ward round, you see a 78-year-old woman who is being investigated for the hyponatremia, weight loss, and hemoptysis. A mass lesion was detected on the CT scan, which has been biopsied and sent for the histopathological analysis. Your consultant has a high suspicion that the patient may have a bronchogenic carcinoma. From the list below, select the most likely type of bronchogenic carcinoma that would explain the above patient symptoms. Large cell carcinoma, small cell carcinoma, adenocarcinoma, squamous cell carcinoma, alveolar cell carcinoma. Yes, Varun. Why it is adenocarcinoma?
Sir, this person is a non-smoker, and among the non-smoker, this is the most common. Like all are also possible, but
Mhm.
this one I felt
Okay. So do you think in a adenocarcinoma they get a hyponatremia and all?
would be possible, sir.
It's possible. Where did you read? Fine. So go and read it again. Anyone? Any other comment? Anyone? Any other comment? We are still lots of doctors in the group. Last couple of questions. Probably we cover one more question after this, but try to understand. So let me tell you the one excellent, very high yield point for the lung carcinoma. Probably will be. Then will we stop? I guess no problem. But I want you to understand lung cancer, lung CA, the biggest tobacco smoking, tobacco is the biggest risk factor, right? Right. So lung cancer, biggest risk factor if they ask, is the lung cancer is a smoking. First question in exam, right? Second question in exam for lung cancer, screening. So screening, second question, when to start, which age? 50 years of age, you start the screening and stop at 75 years of age. To whom you screen? Those who are taking 30 pack per year, they are the candidate to non-smoker. There is no not required. Third, what taste? So three question in exam. Screening age, to whom you screen, high risk, how you screen. That is the third question. How you screen? Low dose CT scan. This is the recommended, right? So low dose CT scan. So this is the screening method for lung cancer, right? Third question in exam. What is the most commonest histology you found in lung cancer? Most common histology. So if they ask most common histology, adenocarcinoma, almost 70% of the patients. What is the most common histology in a smoker? It is a squamous cell carcinoma. Answer will change. What is the most common associated with hyponatremia and paraneoplastic syndrome? Small cell. This is squamous cell. Don't get confused. Small cell. This is small cell. This is squamous cell, right? So this is associated with paraneoplastic syndrome, right? Third question in exam. Fourth question in exam. What is the tumor marker associated with lung cancer? Tumor marker. So most commonly we do in clinical practice is a CEA, carcinoembryonic antigen, that is called CEA, right? Fifth question, which is the most dangerous, highest spreading and poor prognosis amongst all histology of lung cancer? Answer is small cell. What is the best staging tool for lung cancer patient? Which is the best test by which you know that the stage of the cancer? Answer is PET CT scan. These are the very commonly high yield questions asked in a various different way in the exam. So in a one page, I try to compile several question in a one question, right? So don't get confused in the exam when they ask you, right? You can take a picture of it. Everything is there on our website. So if you go in oncology section, right? Everything whatever I written from there as well, right? So this is what the thing is, right? So let me go to the next questions related with this lung. I want to tell you something more about the lung. If they ask you which cancer has a highest mortality across the globe, answer is a lung cancer, right? So in lung cancer, maximum number of people die in short period of time globally. So if you have breast cancer and lung cancer, right, lung cancer is worse than breast cancer because the mortality is very high. Usually they diagnosed in advanced stage, right? And here, let me tell you again how we histologically classify lung CA. There are two things in lung CA. One called as a NSCLC, one is called SCLC histologically. This is histologically important. They ask in the exam. This is called as a non-small cell lung cancer. This is non-small cell and this is small cell. Small cell lung cancer. It's like Hodgkin's lymphoma and non-Hodgkin's lymphoma. One is Hodgkin's lymphoma, one is HL, one is NHL. This is SCLC, one is NSCLC. Here the three main etiology comes in non-small: adenocarcinoma, squamous cell carcinoma, large cell carcinoma. And here small cell, the name itself suggests small cell. That's it. If you see the statistically, right, 85% is a non-small cell and 15% only is a small cell. Amongst this 85%, 70% are this. This is almost 25, 30%, and this is less than 5%. This is statistically just you to get understand. This is commonly seen in a non-smoker. Non-smoker, this is commonly seen in a smoker. These all three are the non-dangerous. They are cancer, obviously dangerous, but this is if they ask amongst which out of 1, 2, 3, and 4 most fatal, then small cell. Usually present in advanced stage, either stage or 3 or 4, or they many a times present with the brain metastasis. So small cell has a bad prognosis. Small cell needs to be treated promptly. And at what, I mean, I'm treating almost for more than almost close to 20 years now, lung cancer patients. So whenever I see the small, it is usually in advanced stages and with the brain metastasis. So we give first the radiation to the brain, RT to the brain. And this is all the same thing what I explained you in a schematic way, right? And last but not the least, let me finish it off. So I will be another differentiating point when you are reading, going into the round, right? When you are going into the round, how you differentiate lung cancer, I mean, histologically. So there is a adenocarcinoma and squamous cell carcinoma. So squamous cell is a central and adenocarcinoma is a peripheral. So adenocarcinoma, right, usually present very late. Why they present very late adenocarcinoma? Why they present late? Because it is a peripheral disease, and when they are getting enlarged, bigger, and they obstruct the airway, it takes a lot of time. While squamous cell and small cell are the central. right? So they usually present with the central lesion. So when there is a main bronchus, they present early in the disease, usually early, because they have obstruction. They immediately go to the doctor and they diagnose. Here, if it is a peripheral small 1 centimeter lesion in adenocarcinoma, it become 2 centimeter, 3 centimeter, 5 centimeter, quite big. When there is a lung functions compromise, then they present to the doctor. So this is again a very important point for the discussion, right? So that's all. I think lung cancer, you must read it. Lung, breast, colon, and cervix. These are the four cancers which they ask very frequently in exam. So I tried little take bit in detail. So whatever the questions they ask you in the exam, you can answer very easily. So that's all. Thank you very much all from my side today. Before I finishing the class, I would like to have a quick review and quick feedback from the new doctors who joined first time. Just try to understand, or anybody who enjoyed this class or something new for them in the class today. So I would be happy to have a couple of minutes the feedback of my class quality. Open for all. I would be glad. Today is a Guru Purnima, and in India we call it that somebody who is your teacher is a guru. Yes, no one, no comment. Anyone. You did not learn anything new. You knows everything, each and everything. Whatever I explained you, you knows everything. Great, wonderful. If you knows everything, then my class is no more
Hello,
required, I guess.
this is Dr.
Yes,
Venkatesh here. The class is very informative, sir. So what are needed for the exam and the explanation and how to rule out the options. That is what is very much needed in an examinations like PROMETRIC. So this is very much important. And I just went through. I didn't fully sit in the class, but whatever information I heard, it is very good and very informative. Thank you very much.
fair enough. I'll share this PowerPoint, sir, on our channel so you can subscribe it. You will get all updated videos, notifications as well on our YouTube. Right? Anyone else?
Sure, sir.
Thank you very
Sure,
much
thank
for
you.
your kind
I
feedback, sir.
had your
I appreciate it.
question bank also, sir. It is I went through your
Wonderful.
question bank also. It was very important. Thank you.
Wonderful. So everything is on the website. Nothing, this all slides from our website only. Don't worry. But I'll just try to compile it properly. Okay, thank you very much. So let's enjoy your Sunday and keep in touch. I will share this PowerPoint with each and everybody. Thank you very much and enjoy your Sunday. See you with the next class. Thank you very much.